Thank you. I'm going to go ahead and call to order the February 9th meeting of the Senate Committee on Health and Human Services at 3:34 p.m. We've been informed by our Senate Secretary that for the purposes of roll, I can just note who is here. So for the record, I'd like to note that Senators Spearman, Keffer, Harris, and Hardy are present, and we do have a quorum. Just want to remind everybody that as we're moving into this virtual world, you've probably heard this a few times before, but there are lots of ways to participate. If you found us here, you probably know that all of the committees are on NELIS, which is the Nevada Electronic Legislative Information System, which is accessible from the legislative website. If you Google Nevada Legislature and you get onto the website, there's a banner on every page that has a help link. And if you click on that help link, it will tell you all the ways that you can participate. Want to remind everybody that there's an opinion poll function. So if you just want to let us know how you feel about a bill, you can go to that opinion poll, put the bill number in, and tell us how you feel. Or you can register in a committee meeting when a bill is up for a hearing to testify on that bill. In that case, you'll want to know if you're testifying in support, opposition, or neutral, and listen to the prompts from the BPS staff who will tell you when to chime in. You'll be waiting in a phone queue. I do want to note there that we may not always be able to get to everybody who's waiting to testify. And so if you're on the phone line and waiting and you don't make it through, you can also email your testimony to the address that is listed on the agenda for the committee. And you can always do that. No need to necessarily speak. Your information will be shared on the record. All of the senators on this committee are well aware of where they can go to read the public testimony that's attached to the bill. We'll get the results of the opinion poll. And of course, we'll be listening to you here today. So just want the public to feel confident that in any of the ways that you choose to participate, every member of this committee knows how to get access to that information and is committed to doing so. So we will get your input. We've received a significant amount of written input on the bills before us today. And so they are posted. That input that we received in time for this committee is posted on NELIS. So with that, just a little bit of housekeeping. Meeting exhibits and amendments should usually be submitted whenever possible 48 hours in advance so that we can facilitate the public's participation and folks can see the information as far in advance as possible. So with that, I'm going to now open the hearing on Senate Bill 69. We have a number of presenters here for this bill today, and I did just want to briefly introduce that this is the bill that is being brought forward by the Washoe Regional Behavioral Health Policy Board. And I did want to note for the members in all transparency that I am a member of that board and chair that board. But the staff member who supports the Washoe Behavioral Health Board will be leading the presentation today. And I'm going to go ahead and turn it over to Dorothy Edwards to kick off the presentation.
Okay. Good afternoon, Chair Ratty and members of the committee. I'll ask your forgiveness for not having great eye contact as I look to my right for my notes. So I am Dorothy Edwards, as I was introduced, and I serve as the Washoe Regional Behavioral Health Coordinator. The board is currently chaired by Senator Julia Ratty, and the vice chair is Steve Schell, who serves as the vice president of the Stacy Matthewson Behavioral Health and Addiction Institute at Renown Health. Part of my duties as the coordinator includes supporting the Washoe Behavioral Health Policy Board, which was established along with 3 other regional boards in the 79th legislative session. During that session, legislators and members of professional and public behavioral health disciplines recognized the opportunity these boards could provide for improvement in Nevada by giving local leaders a more active voice in the decisions that are made as they pertain to behavioral health. Presenters agreed that all regions of the state continue to face unique challenges, especially in behavioral health, and generally agreed that each region is best qualified to address their respective issues. Board composition includes a diverse representation of regional experts in all fields of behavioral health. Subsequent legislation in the 80th legislative session added a 5th regional board to NRS 433, which also outlines membership criteria and board obligations. Through our advocacy for Washoe County, we strive to increase awareness and understanding of mental health and substance misuse across all populations, promote emotional health and wellness, address prevention and treatment of substance misuse and mental illness, work to ensure adequate and equitable access to effective treatment, and support recovery. We're committed to working with state, county, and local stakeholders to address training, data, diversity of services, and fiscal issues as they relate to behavioral health. One method to affect change in regional behavioral health is the unique opportunity that the policy boards are afforded to develop and present a bill draft request each legislative session. Each biennium, the board works on establishing priorities and opportunities for support within the behavioral health community. Through review and analysis of behavioral health data, collaboration and outreach with state, county, and regional behavioral health partners, and a review of existing behavioral health legislation, board members considered subjects or areas that might require or benefit from policy development, revision, and/or enhancement in the field of behavioral health. The Washoe Policy Board was pleased that their bill AB 66 from the 80th legislative session was passed and have continued to support and explore ongoing regional efforts in the area of crisis stabilization. However, in this past biennium, we were also presented opportunities for the board to focus on substance misuse and its impact on our community. A review of national and state surveys, reports, meetings with substance use treatment and prevention organizations revealed that Nevada continues to experience significant issues with substance misuse. I've included a few data points by way of example. The most recent SAPTA capacity report estimated 406,000 Nevadans who are in need of treatment for the most commonly misused substances are not receiving it. According to the National Drug Helpline, Nevada was placed on red alert in November 2020 for an increased risk of death from overdose. Data in the electronic death registry system in Nevada shows there has been a 50% increase in opioid and fentanyl-involved drug overdose deaths from the first to the second quarter of 2020. In 2019, there was a total of 67,400 alcohol and drug-related emergency department encounters. Out of these encounters, 17,000 were related to alcohol as a primary diagnosis, and over 10,000 were drug-related as a primary diagnosis. Our children have been affected by the substance misuse problem as well. I grabbed just a couple of data points. In 2019, 29% of Nevada middle school students and 57% of high school students surveyed in the Youth Risk Behavior Survey reported consuming alcohol other than a few sips. In that same survey, 13% of Nevada middle school students and 35% of Nevada high school students had reported using marijuana. Between 2017 and 2019, the percentage of Nevada middle school students who consumed alcohol before the age of 11 increased by 21%. So as the board reviewed additional data like this, and we received presentations by some of the individuals you will hear from next, our concept for BDR came into focus. We're here today to present Senate Bill 69 and our conceptual amendment, which was also posted on Nellis. SB 69 has several sections, so we've invited subject matter experts who assisted in crafting this bill to outline the issue and then the solution as proposed in the language. Sean O'Donnell, the Executive Director of Foundation for Recovery, will be our first presenter, followed by Natalie Powell, Director of the Nevada Certification Board, and Linda Lang, the Director of the Nevada Statewide Coalition. We appreciate the opportunity and the attention you've given us this afternoon. And Chair Ratty, with your permission, I will turn it over to Mr. O'Donnell.
Please do. And I also wanted to point out for the committee that there are a number of one-page summaries that are the exhibits that go along with this bill that might provide you some helpful summary information on each of the bill components. Go ahead, Sean.
All right. Thank you, Madam Chair and members of the committee for hearing my testimony today. For the record, my name is Sean O'Donnell. I am the Executive Director of Foundation for Recovery. We are Nevada's statewide recovery community organization and charitable nonprofit governed and led by people in recovery from substance use disorders. I will be introducing SB 69 in our support of the bill with amendments for the required certification of peer recovery support specialists and supervisors in Nevada. I am also a person in recovery and celebrated 4 years on January 5th of this year. Today, I am fortunate to lead a team of trained peer recovery support specialists and volunteers who provide mentorship and support at no cost to anyone in need. Many of us feel compelled to do this work, almost as an obligation, to reach out and help the next person who is struggling. Every day, I witness hope and transformation as people seeking assistance connect with others in recovery who share similar life experiences. As you had heard from Dorothy Edwards, there is a substantial gap between those who need services and those who receive them. We are also headed into a period with a forecasted rise in overdoses and the number of people in need of services due to the pandemic. There are a myriad of reasons why so many Americans and Nevadans are not receiving behavioral health care, both individual and systemic. Difficulty navigating systems of care, no regular access to a provider, prohibitive costs, negative stigmas towards people who use substances, lack of time, and no transportation are just a few. The workforce of peer recovery support specialists is well established across the country and rapidly emerging here in Nevada. The peer recovery support specialists use their lived experience and training to connect people with resources, act as a mentor and model recovery behavior, build relationships, and help participants set goals and build recovery plans. Peer recovery support specialists are utilized in a variety of settings, including human services nonprofits and agencies, community centers, hospitals and clinics, behavioral health facilities, schools and universities, specialty courts, jails and prisons, and others. Because they are inherently non-clinical and offer a low barrier and accessible service, they are one promising workforce to help close the gap between needing and receiving treatment. The impact of peer support extends beyond improvements to service delivery and also offers positive economic returns. According to a national analysis of peer support providers by the University of Michigan's Behavioral Health Workforce Research Center, a federally qualified health center in Colorado found that for every $1 spent on peer services, the healthcare system experiences a $2.28 return on investment. Also, the Georgia Department of Behavioral Health found that those using peer services as a part of treatment generated a cost savings of $5,494 per individual per year for the state. The problem is that currently in Nevada, we have a voluntary certification process for peer recovery support specialists, which means that anyone can use the title of peer recovery support specialist without obtaining certification, completing basic training and education, or having the supervision to maintain the fidelity of the services. In regards to peer support supervision, our state has no requirement or even a voluntary process for those who supervise peer recovery support specialists to obtain certification or learn about supervising this unique workforce. In a moment, you'll hear from my colleague, Natalie Powell, Director of the Nevada Certification Board, who will explain more about the current voluntary process and certification prerequisites in Nevada. To further exemplify the need for required certification, in 2019, Foundation for Recovery worked in partnership with the Washoe County Health District on the goals of strengthening peer support as part of the Community Health Improvement Plan. As part of this initiative, a statewide survey was sent through a variety of listservs requesting responses from providers about their use of peers in their service delivery. The survey included respondents from Washoe, Clark, Nye, Carson City, Churchill, and Lyon counties from for-profit, nonprofit, and government agencies. Respondents indicated that nearly 64% of peers who were currently working were not certified. and these were just those who had self-reported. We also found that less than 30% of employers who utilize peers require certification for employment. Through the years, we have heard horror stories about organizations who've hired individuals who are still currently undergoing treatment themselves, or maybe they only have a few weeks of recovery from chaotic substance use. One organization stated that their hiring practice was to hire the person in the program who has the most teeth. Additionally, we have heard from the people we serve about peer recovery support specialist staff not adhering to professional or ethical standards. With the anticipated growth of this field to address service gaps, we believe that peer recovery support specialists and supervisors should meet the standards for certification by the Nevada Certification Board to ensure a competent public and behavioral workforce who will provide quality care to this vulnerable population, those of whom we keep losing to overdose and suicide. Required certification does not create any substantial barriers for peer recovery support specialists, but helps our state standardize the peer recovery support workforce. Certification provides public protection and quality care. It requires a demonstration of competence and proves that the peer recovery support specialist and supervisor are well-trained, educated, and skilled in providing appropriate services. This bill seeks to address this problem by creating a straightforward process for certification that will ultimately create several benefits for Nevada and the workforce, some of which include basic standards for employers, solid baselines for education and continuing learning, standards in our code of ethics and practice, standards in language and the titles that we use. It will elevate an entire workforce of people like me, people in recovery, and it will allow for better workforce analysis and labor statistics. Overall, and most importantly, it protects the individual, the peer, and the public. What SB 69 aims to do is define peer recovery support specialist and peer recovery support supervisor using nationally recognized definitions. Require certification for anyone holding this title or providing these services, if they're being compensated, to be certified by the Nevada Certification Board, which ensures proper training, continuing education, proficiency, and reciprocity with other states. Requires the Board of Health to adopt regulations providing for the imposition of an administrative fine against persons who engage in peer support or hold the title of peer recovery support specialist or peer recovery support specialist supervisor who aren't currently certified. If the Nevada Certification Board ceases to certify peer recovery support specialists or supervisors, the State Board of Health will adopt regulations for the certification of peer recovery support specialists and supervisors. This bill is not intended to increase any current training or education requirements for certified peer recovery support specialists, increase fees paid for certification, hinder or interfere with volunteers who are currently providing peer support services, or to criminalize people in recovery. In previous sessions, I should note that there have been similar bills which sought to mandate the certification of peer recovery support specialists. The recovery community and providers of peer support had openly opposed these proposals for many reasons. They did not align with the fidelity or efficacy of peer recovery support or national standards. They criminalized people in recovery. They restricted serving in a volunteer capacity. They required a formal medical diagnosis prior to engaging in services. And ultimately, they restricted access to these inherently low barrier community support services. But the proposal before you today was drafted differently. It was drafted with input from peer support stakeholders and providers across Nevada, with assistance from other peer recovery support networks with similar state statutes. And most importantly, with input from consumers, the very people who give, receive, and utilize these services every day. Thank you so much for hearing my testimony today. I will now turn it over to my colleague, Natalie Powell, Director of the Nevada Certification Board, to explain a little bit more about our current voluntary process. Thank you. Madam Chair.
Thank you. Ms. Powell?
Yes. First of all, I want to thank you, Senator Ratty and committee, for allowing me the option to speak today. I'm here, for the record, this is Natalie Powell, the Director of the Nevada Certification Board. And I'm here to provide a brief history of the Nevada Certification Board, or NCB, and answer any questions about the board or the certification process. I'm just going to pull up a document to make sure. Thank you. So NCB was established in 2016 as a secondary affiliate member board of the International Certification and Reciprocity Consortium, or ICNRC. ICNRC's mission is to promote public protection by offering internationally recognized credentials and examinations for prevention, substance use, treatment, and recovery professionals. So individual states may maintain up to 2 ICNRC boards if needed. So you're an affiliate member board from your state or from your country, since it's an international organization. And these boards can license or certify behavioral health service providers in prevention, treatment, and recovery. So NCB was granted permission to even apply to ICNRC by Nevada's primary ICNRC board, which is the Nevada State Board of Examiners for Drug, Alcohol, and Gambling Counselors. They gave us permission in 2016 to apply to be a secondary board to ICNRC, and we were officially voted into ICNRC at the fall 2016 meeting of all the state and international member boards. And our task is to, or charge is to provide a voluntary certification process for peer recovery and support specialists and prevention specialists in Nevada that would either meet, at the minimum meet, but also exceed ICNRC standards. So we were a secondary board that had these 2 certifications. So peer recovery and support specialists, which are the topic today, and then prevention specialists in Nevada. And then 2 years later in 2018, the Nevada Certification Board was asked by the Nevada State Division of Public and Behavioral Health to provide a similar voluntary certification process for community health workers. So we're currently providing voluntary certification for 3 occupations in community and behavioral health. And in terms of, our mission and vision and the importance of certification, I ask you to please refer to the 1 sheet for more information on the board, contact information, and links to the Nevada Certification Board and ICNRC websites. Since we're here today to discuss peer recovery and support specialists, I wanted to share a little bit about our history with that certification specifically. And again, I'm available to answer questions later on. In 2017, after we were granted ICNRC status, we held an ICNRC endorsed pilot or grandfathering period for our peer specialist certification process. So the purpose of the pilot was really to allow certification to our Nevada peer specialists that had already been working in the field and were well established, and also to work out any issues in our certification process. If there were any kinks or unexpected barriers, challenges, we would clean that up for our next round of certification. So during the pilot period, we certified 59 peer recovery and support specialists. And since that pilot, we've certified an additional 91 peers. So we now have a total of 150 certified peer recovery and support specialists that are working in the state of Nevada. Additionally, we have 242 peers who've started their applications with the Nevada Certification Board. And the reason we have so many is that the application, they can take up to a year to complete. So they consist of these certification applications for our NCB certification for peers. You need proof of a high school diploma or equivalency. There's a minimum 46 hours of Nevada state approved specialized training in the ICNRC peer domains. And we have 2 state approved training organizations. One is Foundation for Recovery, and another one is CASAT, the Center for the Application of Substance Abuse Technologies at the University of Nevada, Reno. So you need to have that specialized training in the peer domains. You need to have 500 hours of supervised experience in those peer domains and pass the ICNRC peer recovery examination. Additionally, to be a certified peer in Nevada, you need to have lived experience in substance abuse or mental health or process addiction, and to have been in recovery for a minimum of 2 years. We want people to be stable so that they can help others. And the ICNRC peer domains that I was talking about that you need to demonstrate proficiency in include advocacy, ethical responsibility, mentoring and education, and recovery and wellness support. So there's a lot more to our board, but I wanted to keep it concise, and I'm available today to answer any questions about the Nevada Certification Board or the certification process. And I'm going to now turn the presentation over to Linda Lang, the director of the Nevada Statewide Coalition Partnership. Thank you very much.
Thank you, Ms. Powell. So we're shifting from peer recovery support certification parts of the bill now to the substance use prevention parts of the bill. Ms. Lang, please go ahead.
Thank you. Good afternoon, Madam Chair and members of the committee. For the record, my name is Linda Lang, and I'm the director of the Nevada Statewide Coalition Partnership. In my role with the partnership, I support and advocate for the field of prevention, and today I am here representing Nevada's substance misuse prevention coalitions. I will be introducing the 3 sections of SB 69 that relate to prevention. The field of prevention is often thought of as providing direct programming to youth to reduce the likelihood of them using substances or engaging in other unhealthy behaviors. Even though this is an important component, focusing on youth alone will never prevent issues from escalating in a community. Prevention must occur at all levels of the socio-ecological spectrum and involve all sectors of a defined community. Nevada's certified community coalitions implement science-based interventions and evidence-based programming in alignment with national best practice standards. Substance misuse coalitions are singularly situated to deal with all drug trends because they have the necessary infrastructure in place to effectively address drug-related issues within their communities. As members of the Community Anti-Drug Coalitions of America, which we refer to as CADCA, coalitions echo their belief that prevention of substance use and misuse before it starts is the most effective and cost-efficient way to mitigate the drug crises facing our nation. So basically, prevention is all things that occur before a person develops a substance use disorder. An example is how this state responded to the opioid crisis, from local level strategies to legislative policy changes. Limiting the number of pills that can be prescribed to a patient, that is prevention. Locking up prescription drugs to avoid diversion, that is prevention. Keeping prescription drugs from being put into the environment and out of the hands of youth through drug take-back days, that is prevention. Training communities at large in how to safely administer naloxone to avoid overdose deaths, that is prevention. Educating parents on how to detect signs of substance use in their families, that is prevention. And yes, teaching youth the risks of using substances and other positive coping skills, that is prevention. This multi-pronged approach to the opioid crisis in Nevada was effective in reducing availability and usage in the state. Now coalitions are pivoting to address data trends specific to the use of marijuana. 10-year high school trends specific to past 30-day use of marijuana show an increase, with the largest increase from 17.9% to 19.8% occurring after Nevada legalized marijuana. The perceived availability of marijuana among high school students surveyed in 2019 indicated 49.8% felt marijuana was very easy or fairly easy to obtain. And vaping marijuana as a method of use increased from 2.1% to 14.1% in 2019. Using this important data, mobilizing all the sectors of the community, and implementing evidence-based strategies will move the needle on this issue, just as it did for opioids. And that's the power of the community coalitions. The remaining 3 sections of SB 69 all relate to improving upon the substance misuse prevention structure in our state. Knowing the prevention needs and realizing the fiscal crisis in our state, we looked at how to inform trends and conduct prevention work efficiently in order to bring additional prevention funding to the state. The first section supports the move to evidence-based substance use prevention programming to meet current K-12 prevention education standards. The problem lies in that current curriculum or programs may or may not be based on evidence, depending on the specific school or school district. There is now science to support instruction of substance use prevention in school settings from K to 12, and this legislation supports teachers with the tools to do this. Current curriculum and/or programs being implemented will be compiled, and teachers will be provided resources specific to nationally recognized evidence-based programs. This will allow partnering community organizations to fund more school-based prevention programs. The next section addresses the problem of low survey response rates in school districts that use active or opt-in consent, specific to the Youth Risk Behavior Survey, what we call YRBS. The Center for Disease Control funds the YRBS and requires Nevada to have a minimum response rate of 60%. In 2017, the high school response rate was 65.7, and in 2019, the response rate was 67.3. 6 school districts currently use active consent, and 3 of these 6 have response rates that range from 11.3 to 61.8%, compared to the passive consent school districts that range from 72.9% to 96.7%. The YRBS is the only common data source related to youth behaviors available to Nevada's 17 counties, and the only youth-specific survey conducted nationwide for comparison data. The survey also collects core measures that are required to compete for federal funds. This legislation establishes a uniform, passive, opt-out consent process for the state. It also provides parents the opportunity to review the survey and to receive a written notice of how the survey is administered, how the survey will be used, and the persons that will have access to the results. Passive consent requires less administrative burdens, providing a cost saving and greater participation among students, ensures reliable data with less chance of biases and underrepresentation of certain groups. The final section addresses the legitimization of substance misuse prevention coalitions in Nevada. Current references exist in NRS and NAC that briefly defines a coalition and establishes certification. Beyond these references, there is a lack of clarity about their actual role in the substance misuse prevention structure within the state. The current coalition structure was adopted 20 years ago and is embedded in Nevada's local communities without any formal movement to establish them in state statute since. Probably most important is the amount of funding that is leveraged by community coalitions. For fiscal year 2021, coalitions have secured $11,864,320 to support local level behavioral health issues. This legislation will align Nevada with national best practice standards for prevention as established by CAGCA. It will ensure urban, rural, and frontier communities are equally represented within the state prevention system and recognize the importance of community level decision making. And that completes the high level overview of our bill. We are prepared to walk through the sections of the bill at the chair's discretion. Chair Ratty?
Thank you, Ms. Lang. So all of the presenters are prepared to do a bill walkthrough for all 4 of the concepts. I want to point to folks that there is a friendly amendment that is under my name that is on Nellis. So again, because these bills come from community coalitions and were due on September 1st, there was quite a bit of work that happened after September 1st to get the bill to the place where everybody was comfortable with it. So I want to make sure that you are seeing the amendment titled Conceptual Amendment to Senate Bill number 69. I think I already saw some shaking of heads that we don't need a walkthrough of the bill. Everybody comfortable with that? All right, so then we are just going to jump into questions and answers. And so if you could call out which section of the bill that you are looking to know to ask a question out. So that would be peer recovery support certification, YRBS survey, evidence-based education standards, or clarification of the coalition. And if you can indicate if you would like to hear from Sean O'Donnell, who's the Executive Director of the Foundation for Recovery, Linda Lang, who is representing the prevention coalitions, or Natalie Powell, who is representing the certification board that does the actual certification, that would be very helpful. Who has a question? Senator Kieckeffer, please.
Thank you, Madam Chair. Appreciate it. Thank you for everyone for your presentations. I apologize. I read the bill yesterday and I didn't fully see the amendments, so bear with me if not caught up. I apologize. So for Mr. O'Donnell, my question is related to what you indicated as a trigger for applicability, and it was related to compensation. I see nothing in the bill that actually says that someone has to be compensated in order to be captured in this. So the way I read it initially made it look like we were capturing people's AA sponsors. And clarity on that would be helpful.
Yes, thank you, Senator Kieckeffer. You're right. What I had presented included the amendments, the conceptual amendments, which made that clarification that certification would apply to people using those titles or people who are compensated to provide these services.
Then are these services billable under Medicaid or commercial insurance?
They are currently, yes.
Is state Medicaid currently billing for them?
Yes, some providers do bill state Medicaid for these services.
Is certification a qualification for being billed for it? So if you're not certified, can you have your services billed? Is there a difference?
I don't believe certification is required in order to bill for those services.
Okay. Thank you. My second question would be for Ms. Powell, I believe, regarding certification standards. And did I hear you right that you have to have a high school diploma or equivalency in order to become certified?
Senator Kieckeffer, yes, through Chair Reddy, yes, you do need to have a high school diploma or equivalency for each of our certifications.
Okay, can you explain, since this is specifically outlined as non-clinical and lived experience, can you help me understand why that should be a requirement, as you know that's a barrier in our state more than many others perhaps?
Yes, that absolutely makes sense. It's at a requirement of our the International Certification and Reciprocity Consortium. So it's an international requirement that we subscribe to.
Does that make sense?
Well, we did want to standardize the process, and we are absolutely happy to help people with the GED process if that's at all a barrier to work with agencies.
Okay. I mean, if it's an international standard, maybe it's not for you to say whether it makes sense, but it seems like a perhaps unnecessary barrier to me. And finally, for Ms. Lang, is the YRBS survey individually identifiable, or is it aggregated and has no individual information in it?
Linda Lang for the record. Senator Kieckeffer, no, it is not. That is the reason for the required response rate, the minimum required response rate. And there were some exhibits that were provided to you. One of them which shows the response rates across the various counties and how close we are to not reaching that 60%. This last year was 67%. You cannot go through individually at the school districts much lower than the 60% before the data can then be identified. So it is not. But the school districts can receive all of the data and use it as they wish, and it's provided to each one of the school districts that participate.
But on an aggregated basis, not with any individually identifiable information.
Linda Lang for the record. Senator Kieckeffer, no individual information at all.
Thank you. And I apologize, Madam Chair. I did do all my homework for yesterday, so I'm behind. Sorry.
I appreciate that, and I understand. So we'll go to Senator Spearman.
Thank you, Madam Chair. And I think that Senator Kieckeffer touched on part of what wanted. You focused on high school or equivalency. And I think this is for Ms. Powell. Why is lived experience important?
It is, I may refer that that question to Sean O'Donnell, if that's possible. I kind of run the day-to-day administrative pieces of the certification, but he will be able to better explain the importance of lived experience.
Okay.
If that's acceptable.
Sure.
Yes, thank you, Senator Spearman. The lived experience portion for peer recovery support specialists is really like the crux of what makes these services work, really. For instance, I can have the training portion, the learned experience, where I learn about confidentiality, tools like motivational interviewing, advocacy and mentorship, those types of things I can learn in a class setting. But as a peer recovery support specialist, my lived experience, like personal experience with incarceration or experiencing homelessness or just using substances and what that brings along with it, I'm able to relate with an individual, and really that lived experience removes what we call a power differential. So it's different than me going to a clinician who may not have that lived experience. And instead, if I'm working with a peer recovery support specialist, I'm seeing somebody as my peer, right? I'm working with someone who has very similar life experiences as I have and can help me navigate systems and rebuild my life. And we can relate to one another because of those lived experiences.
So Sean, thank you. That makes sense to me. I guess what I hear you saying is something that we talked a lot about last session, and that is cultural competency. Talking to people who understand where you are and what you've been through, and the power differential would be no judgment. Is that correct?
Yes, I think more or less. A great example of that too is, we have this concept of peerness. So if someone is seeking peer recovery support, we would try to match somebody based off of that peerness. So for instance, I'm a member of the LGBTQ community myself. And so it might be more beneficial for me to work directly with other members of that community because we're able to relate more as well.
Yeah, and I guess that's my point. I like this as an overview, and I wish that we would adopt something like that when it comes to especially mental health, because when you're talking about people going through recovery and people who are in a crisis with mental health or emotional health, sometimes having people who don't understand your cultural background can be an impediment. So I like the concept, and I think that you are absolutely correct. Someone who's had that lived experience and who can understand that, and someone who has credibility. If you're a member of the LGBTQ community and you go into the LGBTQ community, that lived experience and the way that you talk and the way that you receive them could give you instant credibility. And that's what I'm talking about when I say making sure that we have mental health providers and physical health providers that represent the communities that are present here in Nevada. So thanks a lot. I just wanted to be clear on that. The other thing, and I think this is for Ms. Lang. You mentioned, some of the particulars about the bill in terms of what it does. We had a bill last time, and I was trying to find the chapter, youth suicide prevention. It was Senate Bill 204, and there are a lot of elements in that bill that would suggest, and it passed, that would suggest there would be a nexus between what you're doing and what the school system is trying to do. I'm happy to talk with you offline and find out how we might be able to look at that and boost support and collaboration for your program.
For the record, Linda Lang, Senator Spearman, I'd be tickled to go ahead and speak with you offline. I'm very familiar with that bill from last session, the report I believe that is required. And if we could accomplish that through that bill, I'd be more than willing to talk to you about it. I'll reach out to you. Thank you.
Yeah, I appreciate that. And I think one of the things that I'm very disappointed in is the fact that we've had so many suicides in Clark County, and just trying to figure out how we have to do better with that. And so there are some elements that, if implemented, integrated with what you're suggesting, I think would be very helpful. So thanks a lot. I appreciate it.
Thank you, Senator Spearman. And I'll just make 2 notes based on your question. The bill would include peer experiences in behavioral health as much as it does substance use disorder. So I just want to make sure that that's clear for the record. And then wanted to note that the provisions in this bill around evidence-based prevention were actually based on SB 204. I think the group saw something good when they recognized something good and chose to model this after it. Senator Hardy, I believe you have questions.
Thank you, Madam Chair. As I think it's Natalie Powell. When I look at the 46 hours, not sure what the 46 hours was versus the 50 hours or the 500 hours. One of my concerns is, what does a person do? Is there tuition for the 500 hours? What do they do while they're waiting to be certified? Realistically, a 12-step program, for instance, uses real people who've had real problems, and the sponsor is not a quote certified person, yet has those life experiences. So if a person is acting as a sponsor and doing something that could be construed as a peer recovery specialist, as long as they don't call themselves a peer recovery specialist, they can still do the same kinds of things that a sponsor does. So is there a problem with people doing something that a peer recovery specialist is doing but is not certified? And how do they become one? Putting through the 500 hours, and what's the process for how much do they have to pay for the certificate over a period of time, or for the license, or why would you become a peer recovery specialist if you're just living your life and working as a sponsor? Those are just
okay. This is Natalie Powell for the record. Senator Hardy, thank you for those questions. They're all very important. I want to start with the differentiation in the hours. So the 46 hours are classroom hours in training. There are 10 hours of the advocacy, 10 hours of the mentoring and education, 10 hours of recovery and wellness support. And then there are 16 hours of ethical responsibility. So it's weighted more heavily towards ethical responsibility. So those are classroom hours that you take. The 500 hours are supervised experience working in these domains. And I can provide you with, we have a matrix of all the tasks that pertain to these domains. ICNRC, they're also a resource for us. So they do a job analysis of every certification, and every credential every 5 to 7 years, where they consult nationwide or international subject matter experts and find out what people are really doing in the field. They also work on updating the examination in keeping with, the best evidence-based practices. So that's where we get those domains provided for us and tasks associated with them. So traditionally in Nevada, and this is something that will probably change, peers have been able to be hired by agencies before becoming certified. So we raised this, we have in the Nevada Certification Board, advisory committees for each certification made up of people in the field, subject matter experts. So a few years ago, the peers felt that there was enough employment available to have people perform these supervised hours before becoming certified. We're changing that now, and part of, I believe, the amendment to the bill, Sean can speak to this, is that we are going to provide for an intern, a possibility of an internship. So you could be at an intern level to get those hours, either volunteering, or many agencies will pay peers for this experience. So far, we haven't had any issue with peers finding paid positions or volunteer positions to accomplish those hours. So far, it's been great. We're going to keep an eye on that and allow for an internship. And then this is something I am going to defer to Sean as a subject matter expert. It's there is a differentiation between an AA sponsor and a peer recovery and support specialist. So we're not able to take any experience as a sponsor or working with Alcohol Anonymous or Narcotics Anonymous with those group meetings, 12-step programs, as peer experience. And if possible, I would like to have Sean address that, because I think he will understand the nuances, be better able to articulate the nuances of those differences. Have I missed any questions?
Before I go to Sean, your concept of an intern gives theoretically somebody a chance to pay tuition or to have some remuneration while they're having their life experience. It's unusual, I think, for someone to, quote, become clean and then step into something that, quite frankly, enough in order to be able to support themselves while they go through 500 hours of, 4 months, basically, of, a program. How are they living? How are they producing? And that's my concern is, are you catching those people? I guess when you say you have 2 years of sobriety, I'll call it, then the sobriety, theoretically, you've been in the community working, doing something, and then you come out and do something for 500 hours. There's a step down in your level of living. So the concept of internship obviously is attractive to me because it gives you something to do and something to earn, and you don't have to go broke in order to be able to help somebody else. I guess that's what.
Absolutely, and in practice, I think that's what's been happening. And this peer recovery and support specialist position has for many been seen as the beginning of a career ladder. So many people move on to become licensed counselors, things like that, social workers. So for some people it is a track, but it is very, very entry level. But they will, I think my understanding, and Sean can speak to this from being an agency that employs many peers, is that they're making as much working as a peer as they would be in any job they were already in. And then in terms of tuition, we charge some of the lowest tuition or certification fees nationally. It's $165 to be initially certified, and $80 of that goes to the test that we're invoiced for from ICNRC, and the rest is for processing. I would say most of our peers, their agency pays for that certification and helps them along with the process. They work with their supervisors. I communicate a lot with supervisors in terms of getting people through the process. So for most people, the agency will cover the $165, and then they're certified for 2 years. Within those 2 years, their renewal obligations are to continue to gain 20 more hours of continuing education units. 6 of those hours have to be in ethics to just keep up with ethics and social media and anything evolving, drug trends. We want to keep ethics in the forefront. And then the other 14 hours are anything within those other peer domains. So, and then that's $100 renewal fee.
Will this make it a de facto outline the current peers that are working in the community?
Pardon me, outline? Will you clarify for me?
Will it make it illegal for a peer to do what a peer is doing now by requiring a certification?
There is a grandfathering period, and Sean wrote these pieces, so again, I'll defer to him, but I believe they have till 2023 to become certified, and we're happy to help anyone move along in that process. You could be a peer recovery intern, or you can be a certified peer recovery and support specialist. There are some allowances for people that volunteer, and specifically for professionals that volunteer as peers, and such as, lawyers that help provide legal advice. And I'm trying to think of the other thing I wanted to say about that. The bill, part of the amendment, there's not a criminal penalty at this point, there's a civil penalty. So if someone were to practice as a peer recovery and sports specialist and not be certified after the timeline, then they would be subject to fines. If they continue to get fines over and over again, they could be held in contempt of court, but that would be as far as it would go. And we wanted to start with that and then reassess next session if there was some need for, a criminal penalty.
And am I allowed to ask about the fiscal note at this point, or not?
My understanding is that we don't have a fiscal note at this point, or the fiscal notes have been cleared, but I'm not an expert on that discussion.
So Senator, what I will say is there have been a lot of amendments to this bill. And so I think that we will get information as we get closer to work session about both the 2/3 majority vote requirement and the fiscal note.
All right, thank you. Thank you, Madam Chair.
You're welcome. And I do just want to make sure that it's clear on the record that the amendment only includes those folks who will be compensated. And then that is intentional to exclude AA, NA, any of the 12-step groups, and any of the other volunteer-driven groups that are supporting folks in recovery. So I just want to make sure that that is very clear on the record. Other questions?
No, Senator, Madam Chair, I just have one. So if someone is practicing and they have not been certified, how do you know? Is it something that they say someone discovers? Do you have anything in place to identify those who would continue to practice and not be certified?
Senator, in the interest of moving this on, I think I'll just directly answer that. It's the same, it would be the same process as any of the other certification and licensing, mostly a complaint-driven process. All right, any other questions? Okay, so we're gonna go ahead and open this up for public testimony. We're going to give folks a limit of 3 minutes. So BPS, if you could open up the line for those who'd like to testify in support of SB 69.
Good afternoon, Chair and Committee. For all the callers wishing to testify in support of Bill 69, please press *9 now to take your place in the queue. Once again, please press *9 now. Okay, caller with the last 3 digits of 398. Please slowly state and spell your name for the record. You will have 3 minutes and you may begin now.
Good afternoon, Chair Ratty and members of the committee. My name is Nancy Bowen, Nancy Bowen. I'm the CEO of the Nevada Primary Care Association. We represent the state's 8 community health centers, also known as federally qualified health centers, or FQHCs. Our members provide integrated primary, behavioral, and dental health care to more than 107,000 Nevadans in more than 40 clinics statewide. I am here in support of Senate Bill 69. Our members' work is affected by at least 2 provisions in this bill: the sections dealing with peer support specialists and the Youth Risk Behavior Surveillance System, or YRBS. Health centers in the state have been working diligently to expand substance use disorder services across the state. State and federal investments have encouraged the certification of providers able to administer medication-assisted treatment to expand options for our communities. We have seen how peer support specialists have benefited the program in our health centers. We believe that clarifying the definition, scope, and responsibilities in NRS will allow this promising provider type to further develop and produce results in our state. NVPCA and our members are very reliant on federal grants to provide services to uninsured residents of the state. In fact, between 2015 and 2020, we brought more than $188 million in grant funding to the state. Securing these grants requires current and accurate data. And one of the most important data sources we use is the YRBS. We believe it is critical for the state to do all it can to support the collection of this data, and we are grateful for the proposal in this bill. Thank you for your time and allowing us to comment on this important matter.
Okay, caller with the last 3 digits of 500. Please slowly state and spell your name for the record. You will have 3 minutes and you may begin now. Once again, caller with the last 3 digits of 500, please slowly state and spell your name for the record. You will have 3 minutes and you may begin now.
My name is Don Gibson, D-O-N-G-I-B-S-O-N. I would like to first off thank the committee for allowing some feedback from my unit. I'm a behavioral health peace officer for the Carson City Sheriff's Office. And I work full-time with a mental health clinician and respond to all community crisis calls related to mental health. A primary focus for my unit, which is the MOSE team, which is the Mobile Outreach Safety Team, is jail diversion and emergency room diversions. My unit is in full support of SB 69 and truly value the support of our community coalition, which is Partnership Carson City, or PCC. PCC is an instrumental stakeholder for the health of our community and a proven leader on raising the quality of life for individuals who suffer from mental illness and substance abuse. Thank you.
All right, caller with the last 3 digits of 584. Please slowly state and spell your name for the record. You will have 3 minutes and you may begin now.
Hello, so my name is Rachel Dunphy, RACHEL-DUNFEE. I am an LGBTQ junior in Silver State, Nevada, and I am a Stand Tall Prevention Team member, and I am in full support of the SB 69. I have been involved with Healthy Communities Coalition as a Stand Tall member for the past 5 years. The Healthy Community Coalition is a great opportunity for youth to get involved in something. Stand Tall is a place where everyone is welcome no matter their past, identity, or sexual orientation. ATC welcomes everyone no matter their walk of life. Stand Tall is a great way to educate yourself and the community on the dangers of tobacco, cannabis, e-cigarettes, and alcohol, especially in youth. Programs like this create an open conversation for youth who struggle with addiction. Everyone has different experiences, and that is why diversity is so important in these kinds of prevention groups. Being active in activities has helped us all learn so much. We focus on preventing addiction, but there is so much more. We touch on varieties of subjects from prevention to mindfulness and even exploring artistic opportunities. Groups like this are very important to the community because they not only teach youth about prevention, but help youth teach the rest of the community about prevention. Supporting coalitions means supporting the world's next generation, teaching us values to last a lifetime.
Once again, callers, if you're wishing to testify in support of Bill SB 69, please press *9 now to take your place in the queue. Caller with the last 3 digits of 079, please slowly state and spell your name for the record. You will have 3 minutes and you may begin now. Once again, caller with the last 3 digits of 079, please slowly state and spell your name for the record. You will have 3 minutes and you may begin now.
This is Joelle Gutman Dodson, JoelleGutman Dodson, and I'm representing the Washoe County Health District in support of SB 69 today. The implementation of peer recovery support specialists in Washoe County is part of and continues to be a part of the Washoe County Health District's Community Health Improvement Plan. The certification for peer recovery support specialists will ensure a better standard of practice, elevate the workforce, help to protect the public, and sets a standard for employers. Additionally, the health district supports an up-to-date and evidence-based curriculum and programs concerning substance misuse and substance abuse disorders in our schools. And finally, we are supportive of every school participating in the Youth Risk Behavior Surveillance System, or the YRBSS, and the opt-out method. The more students that participate in this survey, the better data we have to address the needs of Nevada's youth. Thank you.
Caller with the last 3 digits of 410, please slowly state and spell your name for the record. You will have 3 minutes and you may begin now.
Hi, my name is Vince Collins, VinceCollins. I am the Director of Operations at the Gay and Lesbian Community Center of Southern Nevada, and we are in support of Bill SB 69. We currently are initiating our first substance use program here, Overdose Data to Action program, in which we are employing a peer support specialist, and we vitally need this expertise in launching our program. Having a baseline standards for peer support adds to our professional environment for navigating individuals with linkage to care into services. And by doing that, we impact our entire community, both the LGBT community and the greater community of Las Vegas and Nevada. So thank you and have a great day.
Caller with the last 3 digits of 270, please slowly state and spell your name for the record. You will have 3 minutes and you may begin now. Once again, caller with the last 3 digits of 270, please slowly state and spell your name for the record. You will have 3 minutes and you may begin now.
Good afternoon. My name is Mala, M-A-L-A, Wheatley, W-H-E-A-T-L-E-Y. I am the Director of Pacific Behavioral Health, and I'm in support of SB 69. Pacific Behavioral Health provides mental health services to rural counties all through Nevada. Through our partnership with Healthy Communities Coalition, we have successfully collaborated with the Lyon County School District to provide much-needed school-based mental health services to students. The coalition has provided us with the vital communication, relationships, and connections that have allowed us to provide mental health services to our youth. I strongly believe that the successful connections of specific behavioral health therapists with the Lyon County students is evidence of the collaborative efforts of the Healthy Communities Coalition. The coalition serves as the catalyst for the community connections and is much valued. We have served over 100 students over the past years and have been successful in stabilizing them in the home as well as in the school. And this is due mostly to the collaborative efforts of the Healthy Communities Coalition. Thank you for your time.
Once again, callers, if you are wishing to testify in support of Bill SB 69, please press star 9 now to take your place in the queue. Caller with the last 3 digits of 755, please slowly state and spell your name for the record. You will have 3 minutes and you may begin now.
Good evening. My name is Suzanne Strasser, S-U-Z-A-N-N-E, S-T-R-O-S-S-E-R. Thank you, Madam Chair and committee members, for allowing me to speak this evening. For the record, my name is Suzanne Strasser, and I'm an educator at Mission High School in Las Vegas. Mission High School is the first fully education publicly funded recovery high school in the nation, providing a comprehensive high school education to students in recovery from substance use, abuse, or dependency. At Mission High School, we would use peer recovery support specialists to work through responsible thinking processes with our students to productively address behaviors that interfere with their education due to gaps in their social emotional learning from early onset of use. The specialists will also address concerns that students indicate in their weekly recovery check-ins. The peer recovery support specialist acts as a mentor and models recovery behavior for our students as they recover. These relationships are extremely beneficial and important to our students, especially since students can be apprehensive to obtain a sponsor in their recovery. Rightfully so, since we tell our children all of their lives to avoid strangers. The baseline standards are necessary in providing this low barrier service with safe adults who will provide effective support to our students. Thank you so much for your time.
Okay, caller with the last 3 digits of 974, please slowly state and spell your name for the record. You will have 3 minutes and you may begin now.
My name is Erin Bean, E-R-I-N, B-E-E-N. I am a health teacher at a high school in Carson City School District. And as a teacher, I frequently use local and state coalitions when needing tools to deliver evidence-based substance abuse prevention and mental health curriculum in my classes. I, as a teacher, also use the Youth Risk Behavior Survey data to frame evidence-based curriculum and lessons that are directly identified by youth in my community as red flags. As a teacher, I completely appreciate the passive permission. It is very timely when you have to get all these forms out and returned. So I appreciate that, and I do recommend that going into the future with the YRBS surveys. Coalitions like Partnership Carson City, the one in my local neighborhood, are so valuable. I, as a teacher, want my students to leave class with not only content knowledge, but skills and resources. Countless times, I've reached out to my local coalition, Partnership Carson City, to plan lessons, collaborate in developing presentations, as well as come up with great projects in my classes. Together, we've developed youth opportunities, after school in the community, summer workshops, evening programs, as well as extended learning opportunities in relation to substance abuse prevention, and mental health. And those are what we call as family engagement series. I wholeheartedly support SB 69. From the teacher in the trenches, I rely on local and statewide coalitions to assist me with reaching students within my community with science-based approaches to prevention programming. Thank you.
Thank you. BPS, we'll go ahead and take one more comment in support. If you are on the line waiting to testify in support of SB 69, I'd like to extend my apology to you that we're not going to be able to get to everybody today and invite you to email your testimony to the email address on the agenda. We're going to need to move on after this caller to opposition. And so we'll take one more and then we're going to move on to opposition.
All right, thank you, Chair. Let's see. We do have a few more callers, so please stand by just 1 second. All right, caller with the last 3 digits of 619. Please slowly state and spell your name for the record. You will have 3 minutes and you may begin now.
Hi, my name is Joe, J-O-E, Joanne, J-O-A-N-N-E, Culver, C-U-L-V-E-R. I am bigender, gender nonconforming, and my pronouns are based upon my current gender expression, which are currently she, her, and hers. And I am grateful to the committee, the chairperson of the committee, for giving me this time to be in support of SB 69. As a and in full disclosure, I myself am in recovery, 13 years without a drink or placing a bet. So I really feel like it's important that we do have these standards. I heard some senators having some concerns about people not being able to do this, and I believe that my own recovery is one thing, but being a professional is a completely different thing, and so in supporting these standards, then I'm also supporting my own standards. So that's what really is important, because frankly, Nevada, really is one of the states that leads the standards, and I'm grateful to you legislatures because this is because of you in licensed professionals. I have other issues with that, and you've gotten your email. But what I'm hearing is a support for the standards for SB 69. So I'm going to ask if you do have some concerns about these people who don't have say like a master's degree like I have, they can reach clients in ways that those of us with the fancy letters behind our names cannot. And I think that having those standards just keeps elevating, the need for treatment professionals that we have within the state. So once again, I am grateful that you gave me the time to come out and support this. Thank you.
Okay, thank you. And again, I apologize to those waiting on the line to testify in support. We're now going to move on to testify in opposition to SB 69.
All right, callers, if you wish to testify in opposition to Bill SB 69, please press *9 now to enter your place in the queue. Once again, to testify in opposition to the bill, please press *9 now. All right, caller with the last 3 digits of 611, please slowly state and spell your name for the record. You will have 3 minutes and you may begin now.
Good afternoon and early evening, Senators. This is John Piro, Johnpiro, from the Clark County Public Defender's Office. I am hesitant to testify in opposition because I love so much of everything that this bill does. I appreciate Senator Ratty and the sponsors removing Section 8, subsection 2, which created a new misdemeanor through their amendment. But there is, however, one more section that we are concerned with, and that is Section 16, subsection 10D. Facially, it does not seem to raise a criminal penalty, but it does add the peer recovery support specialist into the growing list of people whom an assault or battery would constitute a gross misdemeanor instead of a misdemeanor. This list has grown quite a bit, even in my short time appearing before this legislative body, so much to the point where the exceptions are starting to swallow the rule. Of course, I want peer support specialists to be protected from aggressive and dangerous conduct, but I do not believe there is a correlation between increasing penalties and reduction in criminal behavior. The DOJ has even studied deterrence in this manner, and the best indicator of deterrence is immediacy of punishment, not an increase in penalty, which most people won't even know about anyway. Moreover, upping the penalty to a gross misdemeanor triggers a jury trial as opposed to a misdemeanor bench trial, which, as all of you know, will increase the cost of prosecuting and defending these cases. Moreover, most of the people that are affected by these gross misdemeanor crimes are both the mentally ill and the drug addicted. Those are the people that we see getting charged with these types of crimes that fall into the gross misdemeanor category. Our position is that this would be a much better bill with that Section 16 language removed, and then we would move into full support. Thank you.
Caller with the last three digits of 931, please slowly state and spell your name for the record. You will have 3 minutes and you may begin now. Once again, caller with the last three digits of 931, please slowly state and spell your name for the record. You will have 3 minutes and you may begin now.
My name is Trey Delap, Treydelap. Madam Chair, members of the Senate Health and Human Services Committee, I support the objectives and intents of the bill. However, I think it needs amending, and technically I am opposed. Regarding Senate Bill 69, as an observer of the hearing this afternoon, I was seeking resolutions to the lingering questions as to the purpose of the legislation. Regarding sections 2 through 15 inclusive, peer recovery support, current law provides for the Department of Health and Human Services, Department of Public and Behavioral Health, and the State Board of Health to establish regulations for peer recovery support. Since 2015, they have chosen not to do so. Why? This question is relevant because it is if the executive vis-a-vis the Department of Health and Human Services and its leadership are not willing to properly engage and regulate peers with adequate legislation and regulatory authority, how is this bill going to improve their ability, or more importantly, motivate them to do so? Regarding Section 26, Prevention Coalitions. Continuing the question of leadership, what is the purpose of codifying coalitions into statute when they allegedly have an established relationship as community-based providers of prevention services already? The governor proposes more than $100 million to be dedicated to reducing, quote, risky and addictive behavior. The bulk of substance use prevention and treatment agency funding comes from formula federal block grants. Federal law requires that the single state agency distribute this funding to the community in response to the community's advice and counsel. 16 to 20% of the allocated federal funds is designated for prevention. If the prevention coalitions had an established and working relationship with the state regarding strategies, efficacy, and delivering this funding directly to the community, then this bill would not seem necessary. And yet here it is. The question again is why? Does the state require legislation in order to ensure that it is distributing funding to the community directly? Will the legislation compel the state to address equity, fairness, and transparency in the distribution of federal funds? Even if a coalition complies with the extensive list of requirements in Section 26, will they be regarded as the primary partner for funding marked exclusively for prevention? Is the problem leadership or mandate that legislation will only fix one of these? Does the legislature have the ability to oversee the inherently executive department functions targeted by this bill? At this point, since this is the first public hearing on this bill, it is difficult to determine whether it will address the unstated problems it seeks to fix. SB 69 in toto is important and needs to pass, but greater than the substance of the bill is confidence in the leadership and culture of the agency charged with enforcing it. Madam Chair, I have no confidence in DHHS's leadership to enact this legislation, since they already have the power to do all the things detailed in this bill, and it's not happening. And SB 69's very existence suggests a wider issue of equity and transparency. Thank you.
Once again, if you would like to testify in opposition to bill number SB 69, please press *9 now to take your place in the queue. Caller with the last 3 digits of 318, please slowly state and spell your name for the record. You will have 3 minutes and you may begin now.
Good afternoon. This is Kendra Birchie, Kendra Bertschy, and I'm with the Washoe County Public Defender's Office. I echo the testimony from Mr. Pirro that we also think that this is a very good bill that has, and we support the peer support community and hope that they are able to help our citizens and help our communities overcome their addictions with this bill. For the reasons that he stated, we are in opposition. And I would just note that when the enhancement was first established, and then there was bills about it way back in 2005, there was testimony about the concern of that the impact would be on those who have mental health issues as well as substance abuse issues. And so I know that the intent of this is to make sure that we help all those who are involved in recovery. And so our concern is regarding the criminal enhancement. And I do appreciate Senator Ratty and the individuals who are working on this bill with all their hard work, and especially with being willing to listen to some of our concerns at such a late hour. So we really appreciate it, and thank you so much.
Chair, at this time, the line is open and working. However, there are no more callers wishing to testify in opposition to the bill.
Thank you. I'm going to open it up to testify in neutral. We have 2 folks from the Division of Health and Human Services, Department of Health and Human Services, who are in the Zoom call, who I'm going to invite to testify first. First, I'd like to call on Dr. Woodard to testify in neutral.
Good afternoon, Madam Chair and members of the committee. My name is Stephanie Woodard, and I'm the Department of Health and Human Services Senior Advisor on Behavioral Health. Based on conversations with the bill's sponsor, as well as the review of the conceptual amendment, we are able to remove the fiscal note as it pertains to the development of regulation. And I have a colleague here, Margot Chappell from the Bureau of Healthcare Quality and Compliance, that also has some testimony to provide.
Good afternoon, committee and chair. Thank you for this bill. And yes, the amendment removes a fiscal note from the Healthcare Quality and Compliance Bureau as well. Thank you for the opportunity.
Thank you. EPS will go on to neutral testimony from the call line.
Thank you, Chair. Callers, to testify in a neutral position on Bill SB 69, please press *9 now to take your place in the queue. All right, caller with the last 3 digits of 394, please slowly state and spell your name for the record. You will have 3 minutes and you may begin now.
Madam Chair and members of the committee, my name is Allison Stevens, Allison, STEPHENS, and I am the statewide Family Network Director from Nevada PEP. Nevada PEP is a statewide nonprofit that connects parents of children with disabilities including mental health needs, offering training and support. These services are recognized nationally as family peer support, and there is a national certification process in place. We also sponsor the organization Youth Move Nevada. The Youth Move Nevada facilitators and mentor are focused on improving child and youth serving systems, in addition to educating each other, motivating each other, and participating in social activities. We so appreciate the willingness of Chair Ratty to meet with us so that we could express our concern that the current language of SB 69 may inadvertently impact our services. We do not believe our services were considered or contemplated as peer recovery support service during the drafting of this bill, and we ask that they be exempt. We're happy to provide any additional information, and in the meantime, I have also submitted this testimony in writing along with a reference document on family peer support. Thank you for your time and consideration.
Caller with the last 3 digits of 739, please slowly state and spell your name for the record. You will have 3 minutes and you may begin now.
Good afternoon, Madam Chair and members of the committee. My name is Joanna Jacob, Joanna, J-A-C as in cat, O-B as in boy, and I'm here as the Clark County Government Affairs Manager. We are testifying in neutral today, and in conversation with Senator Ratty and with Ms. Edwards and some of the proponents, we decided to go and do this in neutral today because we overall support the intent and all of the hard work that has gone into this bill. We reviewed this bill, and I'm really testifying today on behalf of our Department of Family Services and Child Welfare setting. As some of you may know, the child welfare landscape is undergoing a really fundamental shift with implementation of some major policy at the federal level, with the shift towards preventive services and evidence-based protocols that will have to be implemented. And we believe that this model could be employed in the child welfare system for a parent who may be in long-term successful and ongoing recovery, who may be able to help other parents struggling with substance abuse disorder, or other behavioral health disorders, with similar parents who are going through the same circumstances. And so that is why we are in support of the overall goal and intent. And we asked Senator Ratty if she would consider a technical fix, and we consider this friendly, want to work with the proponents on this to just kind of amend in the same requirements as other agencies who employ people working with children or families to undergo a background check with the Central Registry for the collection of information about the abuse or neglect of a child to screen for any substantiated report of abuse or neglect of a child. This is very similar to other background checks in statute. I did file this amendment and listed the other statutes, and I've been in consultation with Senator Ratty and hope to work with her and the proponents on this bill. And again, we are in support of the overall goal and want to thank you for your time and consideration.
Caller with the last 3 digits of 203, please slowly state and spell your name for the record. You will have 3 minutes and you may begin now.
Good evening. My name is Deborah Kamka, D-E-B-R-A-K-A-M-K-A, Director of Operations for Quest Counseling and Consulting in Reno, Nevada. My position is neutral on this bill. My organization has had a relationship with our community coalition, JTNN, for the past 16 years. JTNN is a truly collaborative organization. Along with our law enforcement, they've created the first prescription drug roundup in the state to address the prescription drug abuse, facilitate monthly committees on a variety of drug-related topics, and they work with all interested parties to provide solutions to community substance use problems. My agency values the why RBS trend reports published by JTNN in their biennial prevention plan, and my staff knows to call JTNN when looking for resources like informational rack cards or prescription drug lock boxes for our clients. The coalitions provide great value and local knowledge in their communities and can address community problems at the local level quickly and in a cost-efficient manner. Thank you for allowing me to speak this evening.
Once again, if you wish to testify in a neutral stance on Bill SB 69, please press *9 now to enter the queue. Chair, I do believe that we had one more caller, but it looks like they have either left the queue or hung up. Oh, I'm sorry. There is one more person in the queue right now. Caller with the last 3 digits of 970. Please slowly state and spell your name for the record. You will have 3 minutes, and you may begin now.
Thank you. Madam Chair and members of the committee, my name is Gwen Taylor, GWEN of Reno, Nevada. I am Executive Director of Accept, and I manage that nonprofit as well as supporting my husband's local church. I am a mother and a grandmother. I am neutral on this bill. I have worked with my coalition, JTNN, in Reno since 2002. Our agency has worked with JTNN since 1998. I am so thankful my community has a substance abuse prevention coalition that can respond to community needs such as underage drinking, marijuana use, and prescription drug use. Through JTNN, my agency has been able to obtain sub-granted general funds and federal grant dollars to reach youth through evidence-based programming in schools, after-school programs, juvenile probation, and even in our church. Not only do we impact youth, but we can provide jobs to the community members through sub-granted funds. Whether it's facilitating a committee, bringing a national speaker to Reno, or organizing a community event, JTNN is able to bring community members together to address important drug issues. And Washoe County would not be the same without them. Thank you.
Chair, at this time, there are no more people wishing to testify in a neutral position on the bill.
Thank you. So with that, I'll just note for the committee that we had heard from all the folks who were requesting amendments just in advance of the meeting, and we have pledged to have conversations with them moving forward. So as we get towards work session, we'll be sure to keep you informed. With that, I'm going to go ahead and close the hearing on SB 69 and invite the presenters for SB 70 to come forward. Ms. Flood and Assemblywoman Titus, are you out there?
Yes, well, I'm up.
I am too, and Taylor Allison is on as well. I think just needs to try.
Are others having a hard time hearing Ms. Flood? It looks like you might be breaking in and out a little bit. Jessica will just monitor your internet and maybe have to turn off your video if that continues. All right, who's gonna go ahead and kick off?
Okay.
I'm going to take off if it's okay, Madam Chair.
Please do.
Great, thank you very much. Good afternoon, Madam Chair, and thank you for the opportunity to present SB 70 before you today. Excuse me. For the record, I am Robin Titus, representing Assembly District 38, which includes Churchill and Lyon counties. And I'm here today as a legislative representative to the Northern Regional Behavioral Health Policy Board, and it's my pleasure to introduce this bill which addresses several very complex, very important behavioral health care issues for the citizens of Nevada. This bill is a result of significant stakeholder engagements, meetings, time, and an effort on the part of the board's behavioral health policy coordinator, Jessica Flood, on numerous stakeholders from around the state who met at least weekly for the better part of a year to develop a piece of legislation and proposed amendment in front of you today. We appreciate Ms. Flood's work and that of all the key stakeholders who work so hard to find solutions to these challenging issues. I know that you were given a brief overview when Assembly Bill 69 was introduced just an hour ago or so, but I also want to kind of circle back on how we got here. So in 2017, the legislature passed Assembly Bill 366, which created the 4 behavioral health policy regions, northern, rural, and southern behavioral policy. The bill established a behavioral health policy board for each region. Boards comprised 13 members appointed by the governor, speaker of the assembly, majority leader, and the legislative commission. The boards are responsible for improvement of delivery of behavioral health services throughout the state, and we are required to advise relevant executive branch agencies on regional health issues, identify gaps in services, and coordinate with each other to provide recommendations to the Department of Health and Human Services. Each board is authorized to request one BDR with issues for its region, specific and throughout the state. In 2019, as was mentioned, Assembly Bill 76 was sponsored by the Southern Regional Behavioral Health Policy Board, and it revised the geographic locations, creating a 5th board and establishing the Clark Regional Behavioral Board, which now consists of Clark County and a portion of 9. The 2021 legislative session is a second session to which the behavioral health policy boards have submitted a bill draft, and I am proud to of the work that our board, the Northern Regional Behavioral Health Policy Board, has done over the past 4 years. The board sponsored AB 85 in 2019, and SB 70 aims to build on the success of AB 85 and address additional gaps and challenges existing in the behavioral health care system in the state to better serve most of the vulnerable Nevadans. At this point, I would like to turn the bill presentation over to Taylor Allison, Chair of the Northern Regional Behavioral Health Policy Board, and Jessica Flood, our Health Coordinator. Thank you very much for your time this evening. And Taylor Allison, would you like to go ahead and go forward, if that's okay with you, Madam Chair?
Thank you, Assemblywoman Titus, Madam Chair, and members of the committee. For the record, my name is Taylor Allison. I'm the chair of the Northern Region Behavioral Health Policy Board, representing Carson City, Churchill, Douglas, Lyon, and Story counties. I'm also director of Partnership Douglas County, one of Nevada's substance use prevention coalitions. SB 70 is focused on modernizing, standardizing, and reducing stigma in Nevada's mental health crisis hold process, found in NRS 433A, continuing the work initiated by our previous bill, AB 85, in the 2019 session. For background, AB 85 was brought forth by the Northern Board after we identified the need for policy change.
Excuse me just a minute, Ms. Allison?
Yeah.
You're breaking up like every 4 or 5 words. It's going down to what's almost inaudible. Would it help if you turned your video off and just use audio?
Sure.
Okay, let's see if that works, because it sounds like what you're giving to us is important, and I want us to be able to get all of it.
Great. Let me know if this is better.
Keep going.
For background, AB 85, our previous bill, was brought forth by the Northern Board after a need for policy change to identify these needs. We heard stories of individuals in crisis that were sitting in hospital emergency for 10 days while they waited beds at psychiatric inpatient.
Yeah, I'm not sure. Hold on just a minute. I'm not sure. But is something interrupting your internet? Because it's still, I don't know, can the other committee members, can you hear? Is it just something on my end where it seems like it's like every 4 or 5 words? Mm-hmm.
This is Keely with Broadcast. Permission to interrupt?
Yes.
Would you like to take a short break while the presenters connect by phone?
Yeah, let's do that.
Okay, sounds great.
Okay, we'll take a short recess and we'll be right back as soon as I get this fixed, okay? Thank you.
Hey, can you guys hear me now?
Chair, we are live to the broadcast and we are ready when you are.
Thank you once again to our wonderful broadcast team for helping us out. Let's go ahead and try that again.
Thank you, Madam Chair, and the broadcast team for helping us with the technical difficulties. I apologize. Starting with SB 70, the background, we're focused on modernizing, standardizing, and reducing stigma in Nevada's mental health crisis hold process, found in NRS 4033A, and continuing the work initiated by our previous bill, AB 85, that passed with bipartisan support in the 2019 legislative session. For background, AB 85 was brought forth by the Northern Board after the need for policy change was identified back in 2018. We heard stories of individuals in crisis that were sitting in hospital emergency rooms up to 10 days while they awaited inpatient beds at psychiatric facilities. We heard various interpretations from courts and providers on when the 72-hour clock started ticking, and NRS 433A utilized language that we now know to create additional stigma to individuals experiencing mental health crisis. Jessica Flood, Regional Behavioral Health Coordinator, which you'll also hear from today, established a multidisciplinary statewide mental health crisis hold working group to take a deep dive into the language and to address those critical issues. During the process of developing AB 85, stakeholders gained a greater understanding of the issues and gaps in the law and saw the need for continued legislative effort to update NRS 433A to better reflect the mental health crisis hold system we have today, which leads us to SB 70. Since AB 85 passed, the statewide mental health crisis hold work group has continued to meet. The group has worked collaboratively with state staff and the Division of Public and Behavioral Health to work on regulations, including mandating hospital reporting of mental health crisis hold, clarifying medical clearance, behavioral health transportation, and the process for involuntary administration of medication. And also during the interim, the statewide work group also established educational materials for patients and families to help walk them through what can be a very daunting and complex experience. Seen in the PowerPoint is the cover of the patient and family packet. I believe we also emailed that to the Senate HHS email, but if not, we will make sure that you have that as a backup documentation. The packet reviews the whole process, the current law, patient rights, and if SB 70 passes, the working group will continue to update the packet to reflect modern practice. I'll turn it over to Jessica Flood, our Regional Behavioral Health Coordinator, to review the mental health crisis hold process and the 5 principal changes to NRS 433A proposed in SB 70.
Thank you, Ms. Allison.
Thanks, Taylor. My name is Jessica Flood, and I'm the Northern Regional Behavioral Health Coordinator. Can you hear me okay?
Yes, we can. Please go ahead.
Okay, excellent. So we wanted to start off by providing an overview of what mental health crisis holds are. So they're involuntary holds for people who are considered to be a danger to self or others due to mental illness. So that's for people who are suicidal, maybe homicidal when they're psychotic, or gravely disabled, so they're unable to care for themselves due to mental illness. All 50 states have these laws on the books, and it's the greatest loss of individual rights in our society other than arrest. And it's really based on the constitutional ability of police to detain people when they're at risk of harm to self or others. Nevada's mental health crisis hold lasts for 72 hours, and it includes the first step of detaining the individual and filling out the application on the mental health crisis hold packet. The second is medical evaluation to determine that there are no immediate medical needs that need to be addressed. And then the third step is certifying that the individual is indeed in a mental health crisis due to mental illness. At any time after medical evaluation and certification, the individual can be admitted to an inpatient psychiatric facility under emergency admission. If the crisis lasts longer than 72 hours, a petition can be filed to the court for a court-ordered involuntary admission to an inpatient psychiatric facility, and that can last up to 6 months. And also since 2014, Nevada has also had involuntary outpatient treatment, which is called assisted outpatient treatment in Washoe and Clark counties currently. And that order lasts up to 6 months. I've also included an overview of the mental health crisis hold process for you. I'm not going to go over it, but it is a complex process. And one of the reasons that this has really become a priority for the northern region is that we do get a lot of calls and feedback from families who are trying to understand this process and really get lost in terms of, what the step they're on and where their loved ones are at. So SB 70 made a lot of changes across the mental health crisis hold process. You'll see at the top the elements of the mental health crisis system, which includes the actual mental health crisis, what we're doing to respond to that, detainment, evaluation, and treatment at a hospital or a crisis center, emergency admission to an inpatient psychiatric hospital, involuntary court-ordered admission, and then some of the laws regarding discharge from the inpatient hospital. And we'll step through all of these changes as we go through the presentation. So as Taylor mentioned, we've had this statewide mental health crisis hold work group that's been going on since 2017, a really committed group of stakeholders. They were there to develop AB 85 through the regulation development, through education, and they have worked hundreds of hours to develop SB 70. So core stakeholders on the adult side would be Clark County Judge Yeager, Washoe County Judge Liu, both of whom oversee assisted outpatient treatment and the mental health crisis holds. The Clark and Washoe Public Defenders, Division of Public and Behavioral Health, the Nevada Hospital Association, Rural Nevada Hospital Partners, Washoe County District Attorney's Office, Nevada Psychiatric Association, and law enforcement. On the youth side, we only made a few small changes to the youth process, but we had just a very robust group in participation since this process is new to Nevada. So Nevada Department of Education, Clark County School District, Clark and Washoe County District Attorney's Office, Clark, Washoe, and Rural Child Welfare, Division of Child and Family Services, DPBH again, Clark, Washoe, and Rural Children's Consortia, Children and Family Advocates from Nevada PEP, the statewide family network. So SB 70 is 70 pages long and can definitely seem daunting, but we really feel like we can tell the story through 5 principal changes. So the first big change is that it updates and modernizes the mental health crisis hold law. The second change we focused on was assisted outpatient treatment. The third, conditional release. The fourth was youth mental health crisis holds. And then the fifth significant change was in chemical restraint. So there's several components to updating and modernizing the mental health crisis hold process. So I'll just walk you through those couple of components. And how I'm trying to present this is really identifying what the problem was and then how we tried to adjust that problem. So the first one was updating the mental health crisis process and defining terms. Most of NRS 433A was written in 1975, and it really talks to this system that is not in place today. If you look at NRS 433A, it describes a situation where a law enforcement officer would detain an individual and apply for emergency admission. That's the name of the legal hold or mental health crisis hold. The actual legal name is application for emergency admission. So they would apply for emergency admission, drive the person to an inpatient psychiatric facility, and that person would be admitted. So it's kind of a one-step process. Our now current system has really morphed to adjust, where a person gets detained on a mental health crisis hold, is driven to a hospital or crisis center where they get an evaluation to determine level of care and if they're appropriate to go into an inpatient psychiatric facility. At that evaluation, many people end up getting discharged and returning home. It's not this determined situation where they're headed to an inpatient psych unit. And that's hard to really see in the law right now, and making it very confusing for providers, law enforcement, and for family and peer advocates. So our proposed solutions were to specify the mental health crisis hold process by clearly separating the mental health crisis hold from emergency admission. We also updated the term application for emergency admission to mental health crisis hold. And we provided definitions for many of the things such as the hold, voluntary admission, emergency admission, and involuntary court-ordered admission. The second major change that we made in terms of modernizing and updating the law was around psychiatric deterioration. Currently, we have this in our law right now. It speaks to this concept that people that are experiencing ongoing psychosis are actually damaging their brain, and it's impairing their ongoing functioning. There's a lot of research around this. And so many other states also have this deterioration clause as well. It's not being used in Nevada. And one of the reasons is because it's kind of obscurely squished into the criteria. We attempted to clarify that, but we actually got quite a bit of pushback from stakeholders regarding constitutional issues and also patient rights. So we decided to take out that clarifying language and just pursue education across the state. If there's anything that's been discovered through this process is the real gap in education and understanding around this hold. And so it's hoped that if this bill passes, we can really push forward in having more common understanding across the state on the NRS 433A. The next change is clarifying the family petition for court-ordered pickup. So this was already in the law. It's basically the last ditch effort for families, the mechanism of last resort when families are trying to get help for someone who's in mental health crisis and other measures haven't worked. So examples could be that someone calls 911, asks for law enforcement or someone to come out and talk to this individual who's in their house. That person could be threatening suicide or psychotic. And when law enforcement shows up, that individual can kind of deny that they're in a mental health crisis or that they've been saying certain things that would make people think that they're suicidal. So this can be very frustrating for family members. And this allows families to go to court and get an order so that the individual can get picked up and brought to the hospital. We definitely have heard concerns in terms of creating or keeping a process that really has law enforcement interacting with individuals with mental illness. And I think the Northern Regional Behavioral Health Policy Board and all the stakeholders are all for decreasing interaction of law enforcement with people with mental illness. We hope to build that behavioral health alternative crisis response system. But there's also a place for, that time when law enforcement may need to go out and intervene. Some of the solutions that we're looking at is making sure that it's a crisis intervention trained law enforcement, potentially writing in for mobile crisis teams to assist if available. So we're really open to really trying to figure this out so that people feel comfortable with it. So the other piece, we developed the process so that it's workable. We also removed the ability for spouse, parent, adult children, or legal guardian to petition the courts for direct admission to inpatient psychiatric facility. And that's because it doesn't reflect the process that we have now. Really, anyone, if a court is ordering you to go into inpatient, would like to have an independent evaluation at a hospital so that you make sure that you're appropriate to go. The other thing is going through a hospital or a crisis center, make sure that you're using insurance and we're not overutilizing state beds that could be used for people who really have nothing else. So the last big change for that updating and modernizing the mental health crisis hold law is clarifying hospital and court procedure for individuals who cannot be medically cleared in 72 hours. Again, this is just a muddy process in law, and it was really having hospitals, this happens quite often. And it was making hospitals have to kind of create their own process of what they should do with the courts, leading to a lot of frustration on both sides. So now we have a central process that hospitals can turn to so that they really understand what to do in situations such as this. Okay, I was lying. That was not the last one. This is the last one. So we also updated timelines for notifying guardians in courts in terms of when people are discharging from under a court-ordered involuntary admission. This is important because right now in the law, it says that hospitals have to notify guardians in courts 10 days prior to discharge. As many of you know, our healthcare system moves at a much faster pace than that. And so it is unworkable as it is. So we're amending it so that there's going to be timelines where hospitals have to notify guardians 3 days prior to discharge. The thought is that they should already be working with guardians on that. And then the hospitals need to be notifying courts 3 days after discharge, because patients are actually getting lost in the system right now. Courts will order them into hospitals and they get transferred to different places or discharged. And so from a patient rights perspective, it's important to really be able to make sure that you know where the patient is that's ordered in. Okay, moving on to the second major change. This is assisted outpatient treatment. Assisted outpatient treatment is basically court-ordered outpatient treatment for people with mental illness, with the intention of really providing treatment they need so that they can be stable in the community. So the problem that we have, so a little history. Assisted outpatient treatment was first placed in Nevada law in 2014. And it was really built in Nevada at first as specific programs in Washoe and Clark counties and through federal funding, through SAMHSA funding. Both Washoe and Clark programs have shown great progress. For example, in Washoe County, Judge Liu cited that the AOT program reduced hospitalizations for their participants by 61% and decreased jail days by 73%. So the problem with our law right now is that it's in need of updating. It doesn't have a clear process, and it actually requires that people meet inpatient criteria for harm to self or others before being eligible for an outpatient program. We also got technical assistance from the Treatment Advocacy Center, which is kind of the national expert on assisted outpatient treatment. And they helped us adjust this criteria so that we can be accurate and really know our target population. And they also helped us understand that AOT is not a brand. It's a generic term that's really any level of treatment plus a court order. And with that in mind, we realized that we could create a more flexible program and might be able to find more sustainable ways of developing it in other counties from other than Washoe and Clark, and then also potentially expanding it in Washoe and Clark counties as well. AOT is really important as well because we think that it's an effective part of the criminal justice diversion. It falls at the earliest point of intercept 0. It's court-ordered outpatient treatment for individuals with mental illness who may or may not have come into contact with the criminal justice system. And really trying to get them treatment so that they are diverted from law enforcement interactions, criminal justice interactions, and also unnecessary hospitalizations. AOT is different from specialty courts because we don't have to wait for these people to get brought into the criminal justice system. We don't have to wait for charges to occur. We can see that these people are having frequent hospitalizations or calls to law enforcement, et cetera, and really get them the help they need before they go in further. We also believe that this program is an important part of our system in addressing racial disparity. Minority populations are already at greater risk of harm and death with law enforcement interactions and are overrepresented in the criminal justice system. Likewise, people with mental illness are also at greater risk of harm and death in interactions with law enforcement, and again, are also overrepresented in the criminal justice system. We really see AOT as acting as a mechanism to assist individuals with mental illness by working to stabilize them in the community by getting them treatment that they need. The importance of these diversion programs was really made clear to me. I worked at Lakes Crossing as an intern for a while, and there was one story that stuck with me. There was a Black woman that was running naked down the street, psychotic, got arrested, was brought into jail, spit on an officer, and was charged with a felony for assault against an officer. She ended up at Lakes Crossing, which those competency, treatment, and assessment can take over 6 months. And it was just really a tragedy to see someone like that who could have been assisted by a program like assisted outpatient treatment so far at the back end of our criminal justice system. So what we've done with assisted outpatient treatment is we created a clear and transparent process for individuals so that they know how to apply for it. We've enabled community providers to provide AOT, and that's really exciting because right now only the state can provide these services through funding. We believe that AOT can get reimbursable or reimbursed through insurance, really making it a sustainable program. And then you'll see here that it clearly identifies the target population for assisted outpatient treatment. Okay, the third one out of 5, we're almost there. So we clarified conditional release. Conditional release is a process for people who are court ordered into inpatient psychiatric units. You know, there's usually that 6-month court order. Hospitals often they'll stabilize some of these individuals, and they'll just know that these individuals are at higher risk for deteriorating upon discharge. So some of these hospitals will keep these people for the whole court order because it's going to be an unsafe discharge. They have to hold on to them. But unfortunately, at the end of the 6 months, the individual is stable. They don't meet criteria for an additional court order, so they have to be discharged. And sometimes that discharge ends up looking a little bit like a cliff in terms of, you know, the coordination and community providers. This allows hospitals to discharge people earlier if they're able to set up certain conditions. So the person may need to agree to continue to go to treatment, have a community provider supervise them, or, you know, just check in on them, make sure that they're doing well, and then provide that agreement to the courts. So we really see this as like a discharge plan on steroids in a lot of ways to really try to help those people have a more smooth transition into the communities. So the rural communities would love that. There's often times where suddenly this person just appears in the community and no one knows about it. No one knows what the appointment time is or whatnot, and they just watch the deterioration again. In the urban counties, this was a big one for Judge Yeager. You know, she is the court that facilitates the holds for 20 different hospitals. She often watches those hospitals recreate the wheel over and over again with these people that are coming in and out of treatment. And so she thinks that this will help the court be able to better coordinate those individuals. So with that plan, if the individual comes back in on a mental health crisis, she can provide the last treatment plan, team, and contacts to the next treatment provider to really have that continuity of care. The fourth major change was in the youth mental health crisis hold process. Really, they were some pretty small changes, but I think they have a big impact. The first was that we clarified and changed the time hospitals detaining a youth must notify a parent or legal guardian of holding a youth under a hold. In the current law, it says that hospitals need to notify the parent within 24 hours of the youth being brought into an inpatient psychiatric hospital. No parent wants to be notified at that place. What the stakeholders actually wanted was for the parent to be notified within 24 hours of detainment. And actually with our amendment, we're shortening that to 8 hours. And we think that that's totally doable because any youth that's being brought into a hospital without parental oversight, the first call that they're going to be making is trying to find the parent. The second change that we're making is creating a mechanism for youth to be released from a mental health crisis hold to parents if the guardian or parent agrees to treatment or accepts physical custody of the youth. There's going to be times where the youth is still in crisis, so you can't decertify the hold, but it's still safe to give the youth back to the parent. So we're really just trying to shore up parent rights here. Finally, we made a change to chemical restraint. This was brought forth in large part by Dr. Raven, and Dr. Lisa Durrett also worked on this, as well as the other stakeholders. It's really just updating our definition of chemical restraint to modern innovations in practices and new FDA-approved uses of medications. So our old chemical restraint law is not taking into account how we use medications, and so it's making some of the new practices, which are not for the purpose of chemical restraint, fit the definition of chemical restraint. So I think even though that sounds scary in our bill, it's actually a pretty non-controversial piece of it. Finally, we have our proposed amendments. Like Senator Ratty was saying with the Washoe board, we got our bill submitted and didn't have that much time for turnaround with LCB, so there's a lot of technical cleanup that we're doing. We also addressed change requests from a lot of stakeholders, and we agree with those changes. And we have also added an additional amendment that develops and clarifies cross-county transfer process and mandates court notification when patients are transferred from one facility to another. This has been an ongoing concern for quite a while with stakeholders. Again, patients getting lost in the county transfer process, and so we're really trying to establish a timeline for, when those patients are transferred and what happens in the next county, et cetera. And that's it. So I'm happy to take any questions if you have any.
Thank you. So for members of the committee, I want to acknowledge that this is a long bill with a long set of amendments, 34 pages to be exact. And so my intent would be is to go ahead and have some questions here today. And then I'm going to encourage Ms. Flood to reach out to each of you to see if you want any one-on-one time to kind of go through to be able to match up the amendments with the bill. And then I wanted to let you know that our legal counsel, Mr. Robbins, is also meeting with the bill sponsors to go through the amendments to make sure that what they're proposing legally makes sense. And so there's still some more work to be done there. So we'll be coming back with more information on this one, but also want you to, it's a it's a very complex issue with a long bill with a lot of amendments. So I encourage you to find the time to meet with Jessica if you haven't already. So with that, I'll go ahead and open it up for questions. Senator Harris.
Thank you so much, Chair Ratty. My question is for Ms. Flood, and it circles around Section 22, and kind of dovetailing with that story that you mentioned of the young woman who was, in a mental health crisis and ended up being charged for assault. Is there some way, or do you have any concerns that when a peace officer comes to kind of effectuate this order, I'm guessing people especially aren't going to be willing to go, that the police officer at that time, because of some scuffle or some issue, may end up deciding to take them to jail instead? Are there any safeguards around ensuring that the person is actually going to enter into the mental health system at that point, or will peace officers still be able to essentially decide to arrest them because they're being too aggressive or whatever the case may be?
Thank you, Senator Dallas. That actually is not something that is contemplated in the law, and we'd be happy to work on that with you to see however we can make sure that that person does track into the mental health system.
I'd love to have further discussions. Thank you.
Great, thanks.
Any additional questions? Okay. Seeing no additional questions, we're going to go ahead and open up the lines for public testimony. BPS, if you would queue us up for those who'd like to testify in support.
Absolutely, Chair. Callers wishing to testify in support of the bill, please press *9 now to take your place in the queue. Once again, to testify in support, please press *9 now. All right, caller with the last three digits of 122. Please slowly state and spell your name for the record. You will have 3 minutes and you may begin now. Caller
Good
with the
evening,
last
Chair Ratty. Sorry about that. It took me a minute to unmute. Good evening, Chair Ratty, members of the committee. For the record, my name is Katie Ryan, K-A-T-I-E-R-Y-A-N, and I am System Director of Nevada Government Relations for Dignity Health St. Rose Dominican. I have provided a letter of support to the committee on behalf of St. Rose, and I just wanted to briefly say again how proud we are to be a part of the statewide mental health crisis working group for the last 2 interim sessions. Thank you, and I'm available to answer any questions.
Caller with the last three digits of 318. Please slowly state and spell your name for the record. You will have 3 minutes and you may begin now.
Good evening. This is Kendra Birchie, K-E-N-D-R-A, Birchie, B-E-R-T-S-C-H-Y, and I'm with the Washoe County Public Defender's Office. Good evening, Senate. And I want to start by thanking the sponsor of this bill. My office was part of the working group that helped to work on this bill in order to ensure that we are cleaning up the language regarding our individuals who are involved in involuntary commitment hearings. Just for this committee's information, we represented 2,185 individuals just this past year, so in 2020, in involuntary commitment hearings. Also, I want to just mention with Senator Harris's example and Ms. Flood's example, unfortunately, that is something that happens more often than not, where there are times that individuals are involved in a mental health crisis end up going into jails rather than into the mental health treatment facilities. So that is something that we are hopefully working on, if not this session, continuing to work toward that progress. And I do appreciate Ms. Flood's statements that it is the goal of the stakeholders, from what I'm aware of, to decrease interactions of law enforcement with individuals suffering from a mental health crisis. I would just note that Section 11 regarding the definitions for when someone is to be involved in involuntary commitment, the intent is not to expand and rather capture more people. And so that is something that we'll be following closely with if this bill does become law, just to make sure that we are really focusing on those individuals of need. I would also just note that we are very happy with the way that the assisted outpatient treatment program is dealt with in this law. We know that in this bill, we know that it needed significant modifications since it was originally passed. We represent individuals in that treatment court and are very happy to continue working on that program. So thank you very much.
Once again, if you would like to testify in support of Bill SB 70, please press *9 now to enter the queue. Caller with the last three digits of 080, please slowly state and spell your name for the record. You will have 3 minutes and you may begin now.
Hi, Jim Hoffman, J-I-M-H-O-F-F-M-A-N, representing Nevada Attorneys for Criminal Justice. I would like to echo the comments that Ms. Birchie made. NACJ thinks that this is a good bill, a strong framework, and we're very appreciative of the amendments that were made. Thank you.
Caller with the last three digits of 548, please slowly state and spell your name for the record. You will have 3 minutes and you may begin now. Once again, caller with the last 3 digits of 548, please slowly state and spell your name for the record. You will have 3 minutes and you may begin now.
Joan Hall, representing Nevada Rural Hospital Partners, here in support this evening for this bill. And in transparency, Jessica Flood is employed by Nevada Rural Hospital Partners, my employer as well. We support this as it brings clarity to a very complex bill that has caused many patients and hospitals difficulties. Thank you.
Ms. Hall, is that you? Okay.
Unfortunately, Chair, it looks like she, oh, I'm sorry. It looks like she hung up already.
That was Joan Hall. That was Joan Hall.
For the secretaries, for the record, I don't think it was very easy to hear her name, so that would have been Joan Hall from Nevada Rural Hospital Partners.
Correct.
Thank you, Assemblywoman. Go ahead, BPS.
Chair, at this time, there are no more callers in the queue wishing to testify in support of Bill SB 70.
Senator, you're muted.
Thank you, Megan. Please go ahead and open up the line for testimony in opposition.
All right, callers, if you wish to testify in opposition to Bill SB 70, please press *9 now to take your place in the queue. Once again, to testify in opposition to Bill SB 70, please press *9 now. Chair, the line is open and working. However, it appears that there are no callers wishing to testify in opposition to the bill.
Thank you. Let's go ahead and open the line for those who would like to testify in neutral.
All right, if you would like to testify in neutral position to the bill, please press *9 now to take your place in the queue. Once again, if you would like to testify in a neutral position, please press *9 now. All right, Chair, it appears.
Oh, I apologize.
No, Madam, go ahead. So we're going to take Joanne Millay, who is with us from the Department of Behavioral and Public Health in the video call.
Yes, thank you, Chair Ratty. For the record, again, Joanne Millay. Thank you for the opportunity to participate in SB 70. The Division of Public and Behavioral Health is neutral on this bill. We did submit a fiscal note based on introductory language. I'm not sure, I don't believe that got posted quite yet, but I did, there's some previous language in section 11 that was permissible, as NAMS and SNAMS are the only AOT currently programs, and that petition would fall to us. Without additional staff and other essentials, we wouldn't be able to take on the additional workload. The amendments, however, in section 18 resolve the fiscal impact to the satisfaction of the division, as the amendment added that AOT would be ordered in the county where they reside, and only as such services are available. Another language amendment resolved further fiscal notes if, of course, adopted all the way through these amendments. In section 11.1 D and E, the language regarding an independent evaluation would be ordered and be responsible for the cost of the examination was amended to state, except for the administrator or his or her designee, or the medical director of a division facility in which the person is receiving treatment, or the designee of the medical director of such a division facility. Thank you for the opportunity to put that on record. Thank you.
Thank you. So I believe we don't have anybody else for neutral testimony. Is that correct, BPS?
That is correct, Chair.
Fantastic. Assemblywoman Titus, did you want to make any closing remarks?
Yes, thank you, Madam Chair, and I appreciate everybody's patience. We've gone a long time with this committee hearing, and especially with the two bills that are so very important bills. So I appreciate you hearing them early on in the session so we can get these right, so we can get these amendments forward and get these bills moving through. And I just wanted to thank Jessica and Ali for being involved, and I appreciate all the hard work everybody's been doing. Thank you very much.
Thank you. So we're going to go ahead and close the hearing on SB 70. I wanted to commend both of the behavioral health policy boards for wrangling a lot of stakeholder engagement, starting, I know, with both boards well over a year and a half ago to solicit ideas, to work through these processes, to continue to work on the bills from when they were submitted in September up until the literally moments before the meeting. It was a lot of stakeholder engagement from a lot of different angles. And so I want to commend Nelson Araujo from the 2017 session for having the wisdom to see that having these community boards would be a good mechanism for having local stakeholder engagement to bring us great ideas. So thank you to all of you for that. We are going to just check in with committee staff. I don't believe we have any committee bill introductions that we need to do.
Nope.
Okay. So with that, we're going to go ahead and open public comment. BPS, would you please open the public comment line? And those will be limited to 2 minutes.
Callers wishing to give public comment, please press *9 now to enter the queue. Once again, if you wish to give public comment, please press *9 to enter the queue. One last time for our callers still on the line. If you wish to give public comment, please press *9 now to enter the queue. Chair, at this time, the line is open and working. However, there are no callers wishing to give public comment.
All right, with that, I appreciate everybody's attention to some meaty bills. With that, we are adjourned. Thank you, everyone.